Great. What a wonderful group of people we have here. A very warm welcome. Hi, Sue, Balasubramanian. Good to see you.
Good to
Yeah.
see you all as well. Hi, Chris.
Hi there. Hi, Paul. Good to see you there. If you can do open your videos, it means that we can enjoy seeing you. That would be great. Thank you, Samuel. Lovely to see you. There you are, Antone. Nice to see you. Yeah. Warm welcome. Warm welcome to everybody.
Thank you.
Yeah, this is going to be a really interesting session. And Joy and I are very excited about it. Very excited. It's one of those sessions where you might actually really learn something, which would be great. It should be really good. Do we have Wendy with us? Just want to make sure. Hi, Melanie. Good to have you with us. Hi, Gloria. Thank you for coming. Wendy, there you are. How are you?
I'm fine. How are you?
Wonderful to see you. We're just about to start, and thank you for joining us.
Thank you.
Yeah. So, Wendy, I'm going to make a little introduction, first of all, and then I'm going to introduce Diego, who will speak first, and then I'm going to introduce you, and then you will speak afterwards, and then we'll go to Joy. Is that okay?
Okay.
Thank you. Thank you. Right. Joy, should we kick off? What do you think?
Yeah, perfect. So thank you so much for everyone for joining. And yeah, let's have official start.
That's great. Well, a very warm welcome on behalf of the mental health collaboration of Catalyst Now. I am one of the co-chairs of the mental health collaboration and have been associated with it since the beginning. I'm also on the governing body of Catalyst Now. My name is Chris Underhill, and it's my very great pleasure to welcome you today. In another life, I'm also the founder of the mental health organization, Basic Needs, and it is in that context, as much as anything else, that I really welcome the session today. I can remember us putting together in the year 2000 a MEL program, monitoring, evaluation, and learning, and really thinking about how important that was in those early days. And although now is not the time to tell you all about that adventure, it is my great pleasure to introduce the session today. As we know, MEL is essential for understanding impact, improving programs, and demonstrating effectiveness to funders and to partners. Yet many organizations face the same challenge. How do you build a useful MEL system without creating an unsustainable burden on staff, facilitators, and of course participants? And indeed, that is a really important question. And this session will bring together practitioners from two mental health organizations at different stages of growth to share practical lessons from the field, which is what I'm looking forward to. Rather than focusing on theory or technical frameworks, the discussion will explore real-world experiences, building MEL systems with limited resources, adapting approaches over time, and improving data quality and using data to make better decisions. That, I think, is at the heart of this. We will hear how organizations have approached common challenges, such as selecting meaningful indicators, managing data collection, improving follow-up rates, balancing rigor with feasibility, and ensuring that data actually informs organizational learning and program improvement. The goal is to provide practical insights that participants can apply within their own organizations, regardless of size, budget, or stage of growth. We're going to hear, first of all, from our first speaker, Diego, and then from the second, Wendy. And then we're going to go into breakout groups introduced to us today by Joy Bittner. And I want to give a special shout out to Joy because she has been the mastermind of this program. And all of us who are co-chairs, including her, who are co-chairs of the Elders Council, of the Mental Health Collaboration, are really delighted that she has put in the effort and want to thank her for that. It's my pleasure now to introduce you to Diego. Diego is the Vida Plena M&E Associate since the year 2024, where he leads data collection and analysis to track progress of the group therapy program, report to donors, and learn as an organization. He has a bachelor's degree in economics and one in government, plus 5 years of experience working in consulting firms and non-profits in sectors including humanitarian assistance, education, and land restitution. A warm welcome to you, Diego, and over to you.
Thank you so much, Chris. Just to confirm, can you hear me well?
I can hear you perfectly, thank you.
Yep. And we see your screen as well.
And we can see your
Perfect, thank
screen.
you.
And if you take about between 15 and 20 minutes max, that would be great.
Okay, that's great. Well, thank you so much and welcome everyone. Thank you for joining this session. I'm Diego and I will be sharing with you a little bit about the experience of Vida Plena, monitoring and evaluating the results and the performance of its mental health program. So let me get started telling you what is it that Vida Plena does. So there's this model called group interpersonal therapy, which has been recommended by the World Health Organization as a first-line treatment for depression and chronic anxiety symptoms. The program consists of 8 group sessions, so small groups of people meet once a week for over an hour and a half, and with the guidance of a trained and supervised facilitator, they talk about the symptoms they are experiencing and what is it that is causing them and what can they do about those problems or those emotions that they are feeling as a result of the problems related to interpersonal issues that they are experiencing. So there's evidence of the effectiveness of GIPT or group interpersonal therapy. It has shown results in low, middle, and high income countries, different continents, different population groups. And Vida Plena has been implementing this model with providing attention to over 3,000 participants in Ecuador over the past 4 years. Vida Plena works both with direct implementation, so we hire and train our own facilitators, but starting 2 years ago, we also train government employees so that the different government agencies in Ecuador can also implement the model. So which indicators do we track? We have a few, starting with the PHQ-9, which is a 9-item questionnaire to assess depression symptoms. This is and this instrument can be self-reported, so you can just hand people in a web form or a paper form and they can fill in the 9 items. Tracking symptoms related to having trouble sleeping or eating or concentrating or feeling motivated to do the things that you usually do. So this has been the main recommendation by our partner, which is the Mental Health Lab at University of Columbia. They were the ones who trained the team at Vida Plena so that Vida Plena can train their own facilitators. And their advice is to track PHQ-9 before users start the group therapy and also across the 8 sessions, just to track the evolution of the symptoms of the users. Then we added another indicator, which is the GAD-7. This is also a short instrument that people can self-fill in, and this is to track chronic anxiety symptoms. This is also a recommendation by our partner. In the case of GAD-7, to avoid putting a burden that is too heavy on our users, we don't track the GAD-7 each week. We just do it before and after the program, so we can have at least 2 data points to see any evolution. And these 2 indicators point to symptoms. So these are numbers that we want to see go down. If people come in with high depression symptoms or high chronic anxiety symptoms, we want to see them go down. But then we have added and we have started to explore different indicators to see improvements, things that we want to see go up. So there's life satisfaction, which has been recommendation by the Happier Lives Institute. And now we're also exploring the WHO-5, which is a short instrument, 5 items, to assess overall mental, emotional well-being. I'll talk a little bit more about that in a moment. So how is it that we manage to collect these indicators and actually track symptoms as users go through the program? We have been using mostly Airtable. So Airtable has been described by some of our volunteers and the great team behind this work as Excel on steroids. You can pretty much have online forms and then also store the data and then visualize it. You can have some decent dashboards to see tables and graphs. So we use Airtable, and also it's not that costly. And we have many friend collaborators, but we don't really need to pay a seat for each of them. We just let them use forms to load data, and that way we can do it almost for free. And what we really need to pay for is the users that have access to editing the data, which will be me. Then in Google Drive, we also store additional data about qualitative assessments of our users and how they're doing, how they're feeling, and how much progress they see with their therapy goals. And when do we get to see the data? We meet, we have quarterly meetings, so we try to meet regularly, and then we use the dashboards, which Airtable allows us to do. And with the dashboards, we track the goals that we have defined as a team, and we see if we are getting near the progress that is expected for the time frame, or if we need to make any adjustments or collect additional data to understand why we aren't going the way we expected to. So why having a monitoring, evaluation, accountability, and learning system? It will allow you to assess performance of program delivery. So in our specific case, we have a program that lasts for 2 months, 8 sessions. So we want to know if people are actually attending the group sessions, and if not, why is it? What can we do about it? Is it something related to the facilitator? Is it something about material needs that the users need to meet before being able to attend the group sessions? Are they satisfied with the program? That's information mostly to check how the implementation of the program is going and what can we do about it, or if we should just continue because it's good enough the way it is. Then we can also observe results and impact. So we ask questions such as, do symptoms improve? And that's when we get to use the PHQ-9, compare how the person started and how they are living the group therapy. And also, are these results sustained over time? So at Vida Plena, we have been asking people at 3 and 6 months after they finish the program, again, their depression and anxiety symptoms, to check if the results that they achieve by the end of the program are sustained or not, and why. And ultimately, it can also help you inform decision making. So are we ready to scale? Do we need additional interventions? Questions like that can help you adjust your program and adapt it to the needs and the context of where you're working. So I want to go into detail with one of these elements, which is follow up with participants. So as I was mentioning, we track the PHQ-9 while people are in the group therapy program, but then we do it again just 2 times after they leave, just to have an idea if the effects last over time. And if not, what can we do about it? Should we have people come in group therapy again when they start experiencing depression symptoms again? So this question is to learn and to better understand the needs of our users. So in 2024, we ran a competition among our facilitators. They are the ones responsible for collecting data. So you see them collecting attendance, sending users our weekly forms to collect the PHQ-9 score. And back then, they were also the ones responsible for collecting the 3 and 6 month data follow-up. So we wanted to see what the best way of collecting data was. That wasn't an easy challenge because, again, people had already left the program. So we had no close or regular contact with them, and we had to find a way to reach out to them, and then also to convince them to participate and to share this information with us. So during the competition, facilitators came up with different ideas, including WhatsApp messages and phone calls. So we took notes on their ideas, and we thought maybe we can do something to test the effectiveness of the different alternatives they are exploring and presenting, and try to come up with a decision at the organizational level instead of maybe having each facilitator do their own thing. So we were interested in comparing calling people against just sending WhatsApp messages. Sending WhatsApp messages, it's quite cheap. You can just have a template and send it to everyone, so it will take a few seconds. Also, WhatsApp usage is quite common in Ecuador, so that was perfect for us. But then there was an idea that phone calls could be more convincing, let's say that, or more appealing, since you have to answer right there. While with the WhatsApp message, you maybe can let it on your phone and you'll forget about it. But there was an issue, or maybe not an issue, but there was an aspect to consider with the phone calls, and was that our facilitators are paid by the hour. So having them call each participant maybe for over 10 minutes or more if the participant has questions or is having a hard time understanding the items, will make it last longer and will increase our costs. So we just wanted to be sure that it worked and why before compromising with the decision of calling everyone for their follow-ups. So we decided to compare the two things. Treatment A was sending WhatsApp messages. Facilitators will be the ones responsible for doing that. And then with treatment B, they will also get the WhatsApp messages, but after 2 to 4 days of having sent the WhatsApp messages, if we didn't get a response, we will ask one facilitator to make at least 3 attempts of phone calls to see if people have gotten the link to the web form, if they had any issue trying to fill in the form by themselves, and if there was any way we could support them, or lastly, if they preferred to have us ask them the questions over the phone and just complete the survey with assistance from our facilitators. And also, to be clear, since this was an A/B test, we decided to assign randomly groups to either treatment A or treatment B. We didn't do assignment at the individual level because we thought that will increase the burden on our facilitators, that will make it much more complex to them. So we did a trade-off, and we decided to assign groups randomly instead of individuals. So what were the results? We saw actually a sharp increase in response rate for both the 3 and 6 months follow-up. You can see the graph on the left. So the yellow bars are the ones for treatment A, which is the people that only received the WhatsApp messages. It was actually just one WhatsApp message. We didn't really send follow-ups through WhatsApp. It was just one message. And with treatment B, again, we were doing phone calls for people who had not responded the survey after the one WhatsApp message. So for the 3-month follow-up, you can see the response rate going from 21% to 84%. And then with the 6-month follow-up, the increase is not so strong, but you can still see an increase from 18% to 47%. So we found most people choose to respond the survey on their own, and then others, this was less frequent, but others asked for support to fill it. And how do we know that? When I came up with the list of who were the people that were getting the call, I asked the facilitator to record how many attempts have you completed to call this person, and what's the result of each of the calls, what's the duration of each call. And it will take her about 1 minute to record the data for each attempt. So it was quick, it was easy. Also, it was an agreement with our facilitator that we just had enough data to really understand if the calls were working and why was it that they were working. And that's what I'm sharing with you now, that most people had forgotten or maybe thought that it wasn't really important for us that they filled in the survey. So with the call, just a few seconds, we were able to remind them or to highlight the importance of learning about how they're doing after the program finished. And then again, less frequently, but we found that there was some people that still needed support. One thing I would like to point out is that we excluded from the A/B test elder adults because we know they don't use WhatsApp usually, and it will be complicated for them to even follow treatment A. So we excluded them, but even after excluding elder adults who didn't use WhatsApp, we still had some people that really needed support filling in the surveys. So that's kind of the second mechanism we found that was making these phone calls work. But nevertheless, we think that this was our first A/B test, so it was a beautiful experience for us. It was a chance to raise awareness about tools like this that require randomization, and also to stick to the plan to make sure that treatment A is treatment A and treatment B is treatment B, and there is no confusion over who should be getting the messages or the calls. But then after we did the A/B test, we thought that some things could have been done differently. So after seeing this sharp increase between treatment A and B, we thought, well, maybe people in the treatment A could have also gotten the phone calls, maybe after a certain period of time. So maybe you wanted to actually have just treatment A during 2 weeks to collect enough data to compare A and B. But maybe after the 2 or 3 weeks, you also wanted to call people in treatment A to make sure that you also learn how is it that they are doing after the program.
So Diego, you're pretty much getting to time.
Perfect. I think I have 2 slides left, so I'll be finished soon. Thank you for the reminder. So what's next for Vida Plena? Now we are designing an intervention to tackle dropouts due to social and emotional barriers. This is happening thanks to the support by the agency fund and a researcher that they have matched us to. So really what we want is to understand which barriers are present and how can we respond to that from the very beginning of the program. Then we are also exploring other indicators to better understand the impact of our program. So we have mainly focused on PHQ-9 and GAD-7 to track depression and anxiety symptoms, but we want to have a broader understanding and just have a clearer picture. So we are adding the WHO-5, which is again a short scale where we still have to see how it goes. We already tried with self-efficacy, and we were surprised that our facilitators were having a hard time using it with our users. That's a longer scale. Some questions seem redundant for them. So that has also left lessons for us in terms of how to introduce a new instrument with our team. And then we're planning for our first RCT with support from PhD students and research. So one of the things I would like to highlight is that even if the organization has a limited budget for monitoring and evaluation, volunteers and other organizations are usually quite willing to help you at no cost. So wrapping up, I would just like to highlight some messages. So it is possible to measure results using standard indicators, the PHQ-9, the G87, the WHO-5, self-efficacy are all standard indicators that also happen to be convenient because they will help you compare your results to those of other organizations. Also, A/B tests can be implemented easily while informing decision making. In our case, we decided to conduct an A/B test before committing to start calling everyone, given that it will have an extra cost. And also, questions can be addressed with data and sometimes support of researchers and other organizations. You don't need to do this alone. And also, you can use the tools that you have at hand. This A/B test was conducted at no I mean, the extra costs were really small. We used the staff that we already had as an organization, and then I was responsible for processing the data and coming up with the graphs that you just saw during the presentation. So thank you for attending. Thank you for listening. I'll be glad to have you participate in the rest of this meeting. If you want to contact us, learn more about Vida Plena, you can visit our webpage, our Instagram also account. And if you want to email Joy, who is our founder and CEO, or me, you also have our emails on screen. And yeah, thank you so much. I'll join you again in a little bit.
Thank you, Diego. If you would be kind enough to put your email into the chat, that would be helpful.
Yes.
Then people can be in touch with you. That was very instructive. Thank you very much indeed. It's now our pleasure to welcome Wendy Mbone, who is a Senior Associate Research at Shamiri Institute, where she supports monitoring, evaluation, and learning and data systems for youth mental health programs. She has over 4 years of experience in research data management and statistical analysis, with a focus on strengthening data quality, analyzing program outcomes, and translating evidence into practical insights for program improvement. Wendy, you're most welcome. Over to you.
Thank you. Just a minute as I share my presentation.
Sure. No problem. So we're waiting for it to come up. Yep, it's come up now. And if you can make it a little bit bigger, that's right. Yes, from the beginning, that's great. Perfect. Thank you, Wendy.
Okay.
So Wendy, take 15 minutes or so, 20 minutes max.
Okay, thank you very much. My name is Wendy. I'll be taking you through this monitoring and evaluation presentation about how Shamiri is able to, how Shamiri has been able to measure as we scale. Give me a second, sorry.
I wonder, Wendy, if you go to share, there's you might have been in like automatic playthrough mode. So if you share again. I always have to laugh at these tech companies. They give you so many features, it becomes like overwhelming. You're like,
I can share my screen, Wendy, and then you can just talk it through.
Thank you, Rahim.
You,
Everyone
Rahim,
see
you can
that?
see it now. Yeah,
great,
thank
yes.
you, Wendy.
Okay, thanks everyone. So hi, my name is Wendy. I work in the research team at Shamiri Institute, and I'll be taking you through how a monitoring, evaluation, and learning system has evolved as Shamiri has grown. So we have moved from a system that was mainly relying on end of the cycle evaluation to a system that right now is able to strengthen the delivery in real time as we monitor before we get to the end of the cycle. So through the presentation, you'll see what happens in Shamiri, what we do during implementation, how we respond, the cycle from how participants, how we assess our outcomes, and some lessons we have learned. Next slide. So to understand our the MEL system that we used, we need to understand how Shamiri works. So this is our model where we have a brief school-based mental health support that is delivered by lay providers in a tiered system. So in a 3-tier system. So at the very bottom, we have the lay providers who are trained in the second level, where we have the supervisors. And at the very top, we have the clinical experts who are the ones who support the 3-tier caregiving model, where we have the clinical supervisors and the fellows. So Shamiri intervention is usually brief with 1-hour sessions. They're usually group sessions. And they are low stigma because they are open to all the students rather than only those with specific diagnoses. So the model is also, it's designed to be very affordable. Now, because of this task shifting model, we are able to have many students attending the sessions. And we have evaluated our model in more than 12 studies involving more than 18,000 participants, and the findings published in more than 35 peer-reviewed manuscripts. So it is evidence-based, affordable, brief, and simple enough that it can be delivered by lay providers. Next slide. Okay, so now, because Shamiri is tiered, we have lay providers at the bottom. We need to do more than just measure whether the participants' mental health outcomes improve. And so we also need to protect the conditions that the model has proved to produce in the past. So that's why our MEL measures impact and quality of the sessions that are delivered through the fidelity of how the lay providers follow the protocol, and whether they get enough support. We also check to see how operations are consistent within schools and various satellite locations as we scale. We call these satellite locations hubs, and we call our lay providers fellows. So whenever I mention fellows, I'm talking about the lay providers. Okay, so in addition to quality and scale, we also measure clinical safety to make sure the students who need more care are able to get it when they need it, and in a consistent way. Next slide. So this slide shows the flow of information in our implementation structure. So we have at the bottom the lay providers who forward information to, they get the information from our participants and then forward the information to the supervisors and hub staff. So like I said before, like the hub is like a satellite location that is able to access the schools, and it connects those clinical supervisors and lay providers in the same area to schools to be able to get to the schools. So the lay providers forward information to the supervisors and hub staff, and the hub staff are now able to forward information to the research and other response teams at Shamiri. And from there, information then moves back again to the people in the field after decisions have been made. So in this structure, we see participants in the field being able to fill out responses from their surveys that will give us information about their experience on our intervention. Then our lay providers will provide feedback on the delivery of how the sessions occurred. Some of their sessions will also be recorded. And so then from there, they will upload this information, which is going to be reviewed by the supervisors. Make sure like there's nothing that's missing and everything is being tracked. Then the hub staff are the ones who ensure like the information is complete for all what lay providers and clinical supervisors have submitted. And in addition to that, they coordinate all operational requirements, including making sure the sessions to the schools are scheduled. And if like any person is not available, they make sure like somebody else is there to cover for the sessions and so on. So moving on to the research team, the research team is there checking on all the dashboards and I need to also explain that these dashboards are available for each level. So the lay providers have the dashboard being able to view this, the participants, supervisors being able to view what lay providers and participants are doing, the hub staff being able to view the supervisors, and then here the research team members are able to view what all the different hubs are doing, and they're there now being able to monitor the patterns and inform other relevant teams for action. So there other relevant teams include like the tech team, the service delivery team, the clinical team. If any information has been flagged, they also have their own dashboard views. But however, like the research team is still there to make sure like nothing has been left behind. Then from there, action now has to take place. So decisions have to be made. So when anything has been observed, action is taken by the relevant people. So if it is the lay providers or supervisors or hub staff, they will be the ones to take action, or even response members within the team. Response team members. And then if there's something that's still unclear that we still need to find out from what we've observed in the dashboard, we then throw the question back to the specific level that are able to answer those questions. Next slide, please. Okay, so where we are now. So Shamiri needs have changed as the organization has grown. In the very beginning, in our earlier stages, our questions were to make sure that we prove that Shamiri works. So the questions would be, is Shamiri effective? Is it cost effective? And many rigorous tests were being done to make sure we're able to answer this question. And we were able to answer this question multiple times. So as Shamiri continued to grow, we had more people coming in, and our questions shifted from, is Shamiri working, to how are we able to improve Shamiri as we continue getting to like this larger population with varying needs, and like delivering the implementation with different kinds of people in the different places we're going to. So now it becomes how we're able to optimize at scale. And in the future, what we are looking to, which is the move stage, is can others be able to implement Shamiri in a way that still maintains quality, and at the same time, so we are trying to detect if any quality drift is happening early. Next slide, please. So the challenge we face in this transition is we're trying to make sure we are maintaining safety and maintaining the same quality that we had in the very beginning, and the same effects. And at the same time, do this fast enough that we're not waiting until the end of the cycle, or we're taking a long time, like how long the RCTs used to take. So how we have decided to address this challenge is using a dual engine approach, where we're trying to match this speed and urgency that we have to answer our questions with rigor. So we have this dual engine where the first engine is the evidence engine, and the other engine is the optimization engine. Here in the evidence engine, we answer questions that are high-stake questions that will be addressing core elements of our intervention. So things that if we change, we are modifying our intervention. And so these things include like the length of our intervention, the content that's being delivered in our intervention. And then this thus means like it's another whole intervention altogether, because it's not the intervention that we were doing. So this now is answered through the RCTs, component trials, and cost effectiveness that studies that we were doing, and these still take longer cycles for greater certainty. In the optimization engine, we look at the question of whether we can deliver the intervention that we have already proven, or the interventions that we have already proven. Can we deliver them in a better, more affordable, and a more consistent way? So that's the question. The questions are looking at improvements where the core elements of the model remain unchanged, but we are improving the delivery of how the intervention is going to be done. The methods we use for this to answer these questions are through A/B tests, which we use non-inferiority tests to measure. And they take shorter cycles, faster learning. So we can be able to answer them we don't have to run like a whole RCT to answer these questions. Next slide.
So if you could think about getting towards the end of your talk.
Okay. So the transition that in this transition, we've had to have several trade-offs where in our earlier stages, we had a smaller group that we were using, and our system was paper heavy. It took too long. We still had quality assurance issues that were being found late because of this paper heavy data collection. But now how the system looks like right now, most of the processes have been digitized. We are able to review any data quality issues in real time, and then thus fix the problem while we are delivering rather than later. Slide, please. So this is how our monitoring, evaluation, and learning cycle happens. We are looking to, during monitoring, we're looking to see the signals, strengthen delivery in the current cycle. And during evaluation, we're looking to measure impact after the cycle and maximize impact in the next cycle. So in monitoring, we're asking the question is, what is happening during delivery? Are there gaps emerging? What can we improve while the delivery is currently going on? We track the delivery progress, enrollment, attendance, school engagement, workforce capacity, fidelity, and so on. And what we learn during monitoring is things that we're able to strengthen or investigate before the term ends. During evaluation, we ask the questions whether under the delivery conditions we had during that cycle, did participants still get to benefit? We are looking here at the baseline need at the beginning, if there were any students that had higher need. Here we use depressive symptoms. We track this using the PHQ-8 for depression symptoms. We use GAD-7 for anxiety symptoms, and the short Warwick and Edinburgh mental well-being scale for measuring mental well-being. So here, during evaluation, we are also tracking to see variation across the hubs, and the different conditions that we have been testing in the different hubs. And then we looked at what we learn to see what we can continue, what we need to change, what we need to stop doing, or what we now need to investigate further based on questions that we're able to that arise because of what we have learned during that cycle. Next slide.
So we just have a few minutes left, and we will need to bring it to an end.
So here are the lessons that we've learned in what we have been able to do. So one is design systems around real workflows. So here we make sure like what is going on in the field, what fellows are able to do, what the lay providers are able to do and the clinical supervisors are able to do. We need to make sure that the systems that they are using is appropriate to the workflows. And then design rigor to the risk level. So here, this means like, if we have the load-bearing questions, we need to use the heavy methods. And if it's rapid tests, if it's the operational questions, we use the rapid tests. And then we need to assign ownership of action to decision. We will have different people doing different things at each stage. And sometimes many people doing different things in the same stage. So each action or each process needs an owner, with the action is also given to an owner and the decision being made for that particular process. And they need to know who they are. And the last thing we've learned is to ensure we have data quality, delivery, and outcomes being measured, not only at the end, but throughout the whole process, making sure during delivery, we're able to maintain quality, and even at the end, because if we have high quality data, we'll be able to answer the questions better.
Thank you.
To the end of the presentation.
Thank you. Thank you, Wendy, very much indeed. Very fascinating. Well, we have had an incredible meal today. Diego was able to give us the first course, and Wendy has given us the second course, and we've eaten well. It was a really interesting session. Joy, I think probably I'm going to need to thank everybody for being here and then call an end to the session. We don't have time for questions or breakout, I don't think. Are you happy with that? Are you okay with that?
Yep. Just really appreciate both of the speakers for just sharing like so many details. I think it's always interesting to be in that as you know, as we're in the field, it's always helpful to have those like details. So thank you.
Absolutely. Just to say, I think, just to try to round up a little bit, what we have seen in both cases is the incredible focus and concentration of the organizers, both the managers and the facilitators and the volunteers and so on, who make up a really effective monitoring and evaluation system. It's something that they've obviously given, in both cases, a huge amount of thought to. And as a result of that, we get this very detailed, rightly so, this very detailed description of a monitoring and evaluation system. Both systems have great integrity. Of course, they're serving different clients in different contexts, and that's important. In one case, there is obviously now the use of RCTs as a regular pattern of external monitoring and monitoring or evaluating, in fact. And that, of course, is very important and useful to the organization in question, Shamiri. And I think the distinction between making effective monitoring as a throughout process as it were, an on-time assessment of the progress of the program is very important, and then being able to go to evaluation as a post hoc system of work is also very useful. What I think is also fascinating is the value of the data that is being produced, the value of the data to the managers who are running those two different organizations, the value of the data being produced for important stakeholders like funders, and for that matter, government partners and other partners, really important. And finally, but not least, I think for the satisfaction of all of those involved in the program, whether they are participants or whether they are members of staff, volunteers, and so on, to know that you are doing something effectively is a tremendous part of the work of an organization. To know where you can improve is equally an important part of working for an organization. And you can't really know it until you test it. And we have had different systems of testing and described to us today. We've had different systems of monitoring described to us today, analysis, indeed also, and of course, evaluation. I am most grateful to you, Wendy. Thank you so much for taking the time and the trouble to come and speak with us today. I'm very grateful to you, Diego, for your very eloquent presentation a little earlier in the program. And I think all of us want to join in thanking you very much indeed. Thank you so much for coming. And finally, but not least, thank you to our participants who have been many in number. We have recorded the session, and we will no doubt be able to share it with those who have come. That will be fine. And last but not least, I want to thank you, Lana, for being with us as our support system and our first encourager at the mental health collaboration of Catalyst Now. Many thanks indeed, and goodbye.